Yeah.
What do people do on the seventh day? You said that often they go to the clinic 6 days a week.
They get another dose of medication to take home and take on Sunday. The overdose risk from just doubling a dose is low, and so we feel that the benefit of having a day of rest outweighs the risk of it potentially being misused.
Also, when people stabilize, if you forgive me, if people stabilize, they'll get more of those pickups peppered throughout the day. So as things get better and things are more stable for them, they'll be able to do more things in their life and integrate into life. So their pickups might reduce to even 4, 3.
Oh no,
3
I
days a
mean
week.
the two cases I gave you, both of them came once a month to clinic.
Right.
And so the only reason they were coming to a methadone clinic was just because they can't get it anywhere else. They can't go to their primary care doctor. But they receive the medication as if it were blood pressure medicine or insulin. And that's really what we call medical maintenance. Is someone takes a dose every day, and that's what they need to be healthy. And it's a not really very known about thing, but anyway.
Thank you very much. A couple of remarks. I think I have to slightly disagree with you, Dr. Warren, when you said at the beginning that situation is probably much worse here than in France. I happen to be living in France for a period of time, surrounded by my firm, and I was there, and I realize now it's probably getting as bad as it is in this country.
It's good to know. I mean, the statistics are really based on the amount of prescriptions that Americans are consuming, rather than I didn't mean to minimize any problems in France as well. I know that again that the interventions that are happening in France are progressive, in the sense that there was this medication called buprenorphine naloxone that I mentioned that is more freely able to be prescribed there, so that in some ways things are looking hopeful, but your point is well taken.
I had 2 problems in France and one last year and one a few years before. And every time I was given opioids, not realizing that I was getting opioids and getting sick because of opioids. So in a way, the pain was reduced, but I became sicker simply because of and I stopped taking the opioids. I think, and that's my second point, I think as patients, we're responsible because we don't want pain. So we don't really necessarily want to be treated. We don't want pain. We are living in a world now where pain is unacceptable.
Yeah, I agree with you.
I think it's so we are, the patients are, but the medical profession is also responsible, because you're responding to that by giving us more opioids.
That's right. I think that it's a collaborative effort between patient and, as getting better is with just about anything, between patient and caregiver. The education has to be there, again, the management of pain is something that I totally agree with you. I often say that there are 2 things actually that somehow the modern world has made completely unacceptable that everyone in this world will have. One is back pain. We will all have back pain at some point in our lives, okay? And that the second thing that somehow is unacceptable and that has to be completely erased is insomnia. We all will have nights when we don't sleep well, right? But somehow in our modern culture, when patients come to doctors, and doctors feel a lot of pressure to make sure that is resolved every single day and every single night. And I don't think that that's a healthy or realistic approach to it, because we're risking addiction, first of all, with both sleep and with back pain. And secondly, again, other strategies to intervene are healthier strategies. Sometimes we need those signals of pain in order to know to rest to get better, for instance. So there's a lot to what you're saying.
And the third point I wanted to make, that because we are in the United States of America, there was a story in the Wall Street Journal today in the European page. I don't know if you read it. 36 out of the 50 states, Attorney General are suing because this is an opportunity to get money.
Right.
So we're getting into litigation. Instead of solving the problem, we sue. 36 AGs are suing, and they're hoping to get 120 billion, like in the tobacco case, which is a totally different situation.
Well, I think one thing to remember is your slide about the 5,000 years of history with morphine and poppy. I mean, we need pain medicine. I've had 2 children. I want a world of pain medication. But we need to have the right relationship with it. And then when people have struggles, to offer them treatment, because there's never going to be a world where we don't treat pain. But it just needs to be done sort of smartly, you know, or intelligently, I don't know.
Yeah, and in proportion to, and other, again, pain, look, you know, your point, Dr. Taki, about backing out of, in other words, pain, chronic pain and opiates being given in pain clinics, all of a sudden, sorry, you actually have another condition that I can't treat, so go away kind of situation, is something that we experience, both of us, because patients come, you know, running to us saying, I was in treatment for years, and now all of a sudden my doctor is saying, I'm sorry, the new protocols say that I can't treat you, basically.
And heroin is much cheaper than pills.
Correct.
Significantly
Especially
cheaper.
with fentanyl.
So you're talking about someone who's just cut off of like a very high dose of opioids with no recourse and flu-like symptoms.
Right.
And it's just a reasonable thing that they would switch to heroin.
Right.
It makes sense.
And you know, and I think that, you know, again, pain approaches that use opioids in an intelligent and in a safe way, and in a short-term way, often is the kind of the answer to that, as well as other interventions, whether they're steroid injections, whether it's physical therapy, other ways in which to intervene are also part of the package in a pain clinic. And you know, again, Woodhull's pain clinic is revamping in this way, and you know, I've worked with them to create opioid tapers within, you know, 20% a month, other interventions beginning to be put in, because we're trying to do the best we can to, again, back out of the situation that we've gotten ourselves into, but in an intelligent and a patient-centered way.
Dr. Warren, could you speak a bit about the training for non-professionals, particularly what's being done in some of the organizations, such as at Kips Bay, and we have representation here?
Yes. Mr. Hollingsworth is part of our audience today, and you know, again, I had mentioned in my slides, because we should talk about children as well, that there are many programs that NYC Thrive are trying to put into play. There is, you know, again, we've talked about mental health services that are what we call family-centered. So, you know, not only that it's necessarily the child that is the focus or the identified patient, but the entire family units gets treated. And we know that is to treat a child, you have to treat the entire family. When a child is showing symptoms, and this is, we can have a whole nother symposium about ADHD and all of this stuff, but there's an important aspect of when a child is acting out that is really about what's going on in the family too. So to look at the family as a whole, to support kids in a way that is holistic, is the best interventions that we can possibly. So there are trainings available for families now, and treatment for families, which is a wonderful thing. And I'm going to invite Mr. Hollingsworth to maybe say a couple of words about what he does, since he was.
Well, I'll stand up. Good evening. Thank you for having me. Me and the doctor was speaking briefly about my organization, and one of the things that is on the horizon for my organization is bringing in a mental health clinician on site. So we're partnering with Asta Health Mental Services to bring a full-time clinician to our organization. The clinician will split time between the West Bronx location and our main site. We decided to kind of do that because we ran into problems where our staff wasn't equipped to handle the kids' issues, their problems. So sometimes they get kicked out the door, and that kind of defeats the purpose of youth development. So with the help, hopefully, with the mental health clinician on site, we'll work on really building the kid, like you said, it goes with the whole family and everything that's going on to treat the kid holistically, so we won't necessarily kick them out, but bring them in and bring them closer. So that's kind of what Kips Bay is really I commend my executive director for really taking the lead and really doing that. So that was one of the things that we spoke about as well. And then another thing that we spoke about is that all our staff are trained with the mental health first aid. That was something, again, my executive director felt was important moving forward, and allows us to really try to understand these kids a little bit more. You know, because we're dealing with college and high school kids that are really the direct service to the kids. Might deal with a kid on a different level, but they're stuck with the high school or college kid that might not have the patience or the wherewithal to really understand, like, this is a trigger, or, you know, let's move him over here. So that's the big thing that Kids Bay is doing going forward. So this kind of speaks to that in a lot of sense. So this is why we're here. But thank you.
Yeah, thanks. Preventive medicine. Yes, out and back.
Thank you. If we contrast the west coast of the U.S. to the east coast, we see a plethora of rehab centers on the west coast and go to places, you know, to get prevention, to get treatment, to get follow-up. Very little here. My daughter's peers who face addictions are being sent out to Utah and Arizona, so there goes the family treatment idea. What is the trend here? Why is there such a difference between both?
Well, some of the well-known ones are traditionally well-known ones are out in the West Coast. There is treatment here available. They're well and reputable and facilities, 28-day facilities that I have worked with in the past on the East Coast. But most treatment centers, no matter how far away, if it's a 4-week residential treatment, 28-day, the classic term for it, usually the 3rd or 4th weeks they invite family to actually be a part of the treatment. I don't know whether that was something that was reported back from the families that you were interacting with, but that usually there is a family week where the family is able to participate and understand and be educated, et cetera. It's a really important part. In fact, a lot of times, our division is an outpatient treatment program, so we don't have an inpatient 28-day facility. We have a detoxification unit and then an outpatient program. So a lot of times people will be detoxified, go to a 28-day facility, and then return to us. The patients and working with families and their perceptions and the changes that happen in the dynamics in a family as a person gets better is a really important thing to pay attention to as a person is in early recovery. So the family should be included, and if the family is too far away to come, then there should be collateral communications with caregivers, and there should be education given to the family as well. In terms of the trend, as the West Coast versus the East Coast, I don't think I can speak to that particularly, but.
Is there going to be more treatment centers opening in the East Coast, do you think? Because that's also take the stigma out, right? When it's visible that there are facilities that people in, I don't know.
Yeah, I mean, we refer to a whole number of facilities. Maybe it's just one of those things where I don't know what exposure, but there are a lot of facilities in upstate New York and in Pennsylvania, New Jersey.
And one of the things I'd like to just mention is a lot of residential programs and inpatient units don't offer all 3 forms of medication for opioid use disorder. And so it's really important, if your loved one is struggling, that you find a place that does. Because we know that people that start using opioids in adolescence have much worse outcomes than people that start in their adult years. And so it's, starting with naltrexone makes a lot of sense, moving to buprenorphine, naloxone makes a lot of sense. But then if that doesn't work, don't just keep trying something that doesn't work. Make sure that wherever you're referring to really embraces all forms of treatment, because the risks are too high. You saw that it was a 50% reduction in death. And so whether or not you like a certain medication, it has nothing to do with what a person should be offered. Because we want to keep people alive, we want to give them a chance to recover, and they should be offered all of the medications. And a lot of those places don't offer all of them.
When I was an intern I remember working in the emergency room, and if someone were brought in coma with no known reason, the first thing that we were taught to do was give him a dose of intravenous glucose in case he was in diabetic coma. I just wonder whether naloxone has achieved that status in emergency treatment.
Yeah.
It has.
Yes.
So you just do it.
Actually, they do a finger stick and they give naloxone, I think is the protocol.
Yeah. Go ahead.
I just want to bring up a point which is, I think other people have touched on, which is that for the average person, even the average physician, treatment is very fragmented and sometimes very expensive.
Mm-hmm.
And it seems to me, there's a lot the doctors can do with the education that you outlined, and there's a lot that the public can do, but that our resources, our money really should go into improving the treatment.
And I think parity is very important because I've known individuals, I'm from the Midwest, where there really isn't a lot of treatment. And I've known individuals that have cashed in all their retirement savings to pay for these 28-day rehabs over and over again for their loved ones who are addicted to heroin. And that's just, I mean, in this country with the resources we have, just abhorrent to think that someone would have to do that to get their child some help. So yeah, there's a lot of work we need to do on the fragmented system, and I work on parity for mental health and addiction treatment. Go ahead.
What is the prevalence of, like, you talked about teenagers and people older, but what about younger children? I'm wondering how, I don't imagine it's too prevalent, but God forbid, but how young
Drug
does
use,
this
you mean?
happen?
Like opioid use?
Yeah.
I mean, I think I've heard as young as 8, and usually it was a parent that shouldn't have been parenting, It's not common. Mostly I hear like 13 to 15 is kind of the ages people really start to experiment.
Yeah. And they experiment from, as Dr. Turkey said, they experiment from the medicine cabinet. So again, security, and throw out opioids that you don't need. I mean, don't leave leftover, Percocet from a dentist lying around there's no need for it. Throw it out.
And benzodiazepines as well, like Valium.
Yes.
Valium.
We haven't talked about that at all tonight.
Xanax, Klonopin. That's another wave that's really starting to just take over.
Absolutely.
That we're seeing.
Those for those of you who just are getting aware of that, those are anxiolytic. Those are short-acting anxiolytics that are used by psychiatrists. Really, they're another form of controlled substance. They're not quite as dangerous an overdose as opiates are, but they're very addicting, especially the short-acting ones like Xanax and stuff like that. We detox people from that as well as opioids, and it's so it's good to know as well.
How about in the back?
So I think you said that 80% of addiction is from opiate prescription. The other 20, I guess, is recreational exposure, taking things.
Apparently, yeah. I mean, this is the fact. I'd have to go back and find out where exactly I found that. I'll let you know what my references are there. But just generally speaking, they were saying that about 80% of heroin users were initially prescribed opiates at one time. I don't know.
With this wave, like there's been multiple
Yes,
waves of
right.
opioid use in this country.
Last 20 years.
But this last wave.
Yeah.
And then you said sort of it's a disease. So it's a disease that you sort of need to be infected. You need to be infected with exposure. And then once you're infected, essentially you're saying there's no cure.
So infection isn't quite what it is. It's really a repeated exposure that leads to chronic changes in the body. And I'm sorry to jump in.
That's not
But basically our body's always trying to maintain a level of normal. So if you challenge it with something that changes the state significantly, your body will then try to balance out those changes. And so what you hear from, and we make opioids in our body. That's what relieves our pain when we're, experiencing anything painful or sitting for a long time or anything. And so what happens with opioid users is they use a little bit, their body adjusts, and then they need to use a little bit more, and then their body adjusts. And what ends up happening is after time, you almost get no euphoria, but people will use to feel normal.
tolerance.
And the changes that happen are really around like the decision making in the brain, the ability to sort of like hold the brakes when you have an idea that you probably shouldn't act on. It's really around the circuits in the brain that you probably could speak to much better than I could. But when you use medication, it sort of like calms that whole system down. It allows for people not to be constantly thinking about using or thinking about how they shouldn't be using. And that's what I mean by chronic illness.
There's also, I mean, if you think about something like high blood pressure, there's also a component as well. All of that is true, by the way. but there's also a component that's genetic. Some people never really develop high blood pressure. Other people are more prone to it, and their diet can influence that, right? So it's a little bit of a balance between genetics and also exposure and choices, and so it's a multifactorial thing. But I think, you know, again, diabetes or high blood pressure are good examples of something that has a genetic component, but also, you know, external insults can influence and worsen. Does that make sense?
So I go see a doctor and I get a 1 month supply, maybe even a 3 month mail order supply. You know, you mentioned 5 days a week of treatment. It just seems a significant burden
It's
on the patient. I mean, and maybe in one of your examples, you said they come in once a month because they're assumed to trust and stabilize. Is there any way to improve that? Because I would think that's a hindrance of treating a patient in their own mind, or
Well, I think that, first of all, against recommendations never directly treat any one person. So that's important. And you know, they're all, so when we have guidelines, we're trying to change general prescription practices, and we're trying to change, but no policy can ever address any one person's issues. Right, so it's more complicated than that, I should probably mention. And as Dr. Taki said, there's going to always be a place for opioids, but in general, what I will recommend to patients, whether on benzodiazepines or on opioids, is that you know, it's one of those things where over time, if the prescription stays the same, you're getting less and less out of it because everybody builds tolerance to it. I mean, whether there's an addiction predilection or not, you're going to build tolerance to its effects. So again, if there's chronic issues that need to be addressed, of course they can be addressed. So I didn't mean to be completely shutting the door and saying this is the only thing that can be done, but it should be considered that, you know, sometimes with tolerance building agents, doctors will recommend taking breaks from it if possible, on days where there's less activity or on days where there's less anxiety. Mm-hmm. There are other ways in which, you know, treatment with a tolerance-building, you know, medication can be addressed.
With methadone maintenance in particular, and that structure, that 6-day-a-week structure, it's partially a safety thing. We don't want someone who's not tolerant to methadone getting their hands on methadone, because that could kill a non-tolerant person. It could really hurt someone. And so part of that structure is to make sure in the beginning that someone who's struggling in recovery really has built enough recovery skills, has stabilized in treatment, increased their like level of function in there, and shown to be responsible enough to manage medication. But as they show they have that ability, they get to take home more and more medication. And to your point, is there a way to reduce the burden? France has a much more robust, in my opinion, addiction treatment program, like in general across the country. But the one thing that is similar about France that we have a problem with is rural areas. So rural areas, you may have to drive 2 hours to a clinic, and that means that you're spending money on gas. If you don't live in a state that has Medicaid that covers treatment, you're spending $25 for a dose of methadone in a day, and then you're driving home for 2 hours. And that's a huge barrier. But in other countries like Canada, they've offloaded some of those daily doses into the pharmacies. And so they go maybe 2 times a week to their OTP or to their methadone program. And then they go to their local pharmacy into a little secluded area and get a little bit of their methadone for 3 days in between, and then they go back. And it really reduces some of that that burden of travel and time. The other thing that Vermont's looking at is it's a contraption that is hard to break into, and it allows for the dose to be dispensed within a day. And so they're working on looking at giving people a week's worth of medication that only is released in a daily pattern so that they don't have access, just like they were going to a clinic, to that dose on more quickly than they should. So those are some ideas, I guess.
I think unfortunately it's getting late, but so let's ask one more question if anyone has one hand. Okay, in the back there, please.
Hi. I had a question about treatment programs beyond the 28 days. Can you speak to the viability of places like halfway houses or sober living facilities? From what I understand, those that are Medicaid funded, I've heard can almost be places where it's easy access to things like heroin and other drugs that we're trying to keep away from. So I was curious to see if you could comment about your familiarity with what's available in the city.
You want to take that one? That's loaded.
Well,
That's a very good question.
But my very favorite piece of research is this. So people spend a lot of time trying to put people into groups and to say, like, this type of patient would do well here, and what we actually, when you look at the data, it's the characteristics of the program that predict the outcome for the patient. So if it's a poorly run detox rehab where a lot of things that shouldn't be happening are happening, you're going to have bad outcomes. But actually, it has very little to do with the human being walking through the door. It's just the way that the place is run, and that's my favorite piece of data.
Yes, and also, I mean, you do need to be careful about some of these facilities. It's absolutely true. We're very, very careful about endorsing sober living facilities within the city, just because there's so much difficulty with that. So you need to do your research and to understand and understand the reputation of the facility for sure.
Some of the insurance companies have worked on building capacity at home. So sending out care, like nurses, addiction counselors to the home to almost provide the structure of sober living, but in like your parents' house or someplace that is a little safer and not as at risk for having like drug sales and things like that. Mm-hmm.
Well, thank you. Let's have a big round of applause for our two speakers. Thank you. Feel free to continue asking for some questions, and I know that Sarah is very keen to show how to train with those naloxone kits. So
anyone who's interested in just learning how to use naloxone, are you guys ready to? Caitlin and Corey would be happy to show you how to use a kit and give you one if you'd like one.
Yes, and then, send us your feedback. This is the first time that our group has been organizing such a lecture, so I want to thank again Michelle Warren for coming with this idea and enrolling Matthew was really wonderful. And maybe ADHD, autism, or a real comparison of the French and the American system, because I've been interviewing some specialists in France too, and they had some, things to say, but it's too late right now, and it was too long a topic. But so, thank you very much for coming, and have a safe drive home.
Yeah.
Thank you.
There's only one thing I want to thank by name, because I did it at the end of the lecture. Thank you so much, Marguerite Mangin, and Claudette Carabi, and Claire Tatar, and Dr. Taki, and also everyone else that has participated today. I really appreciate your having us.